Hello everyone, this is Dr. Minister again. Let us now discuss about the antibiotic approach to various infections. Okay, first we'll start with the respiratory system. Okay, first infection is CAP, that is community acquired pneumonia. Okay, when do you suspect a CAP? Okay, the patient presents with fever, cough with expectoration, shortness of breath, and bronchial breath sound or crepitations on auscultation. Okay, and in the CAP you'll find that no pathogen is identified in majority of the cases. Okay, how do we confirm that it is CAP? By X-ray. X-ray will show presence of lobar consolidation, interstitial infiltrates or cavitations also can be there. And confirmation we'll do with sputum, gram staining and culture. Right. Also we can go for serology of atypical pathogens. Okay, what are the atypical pathogens like mycoplasma, chlamydia, legionella, some viral infections, all those. Okay, blood cultures may be helpful prior to initiation of antibiotic therapy. Okay, so what are the empirical treatment and what are the treatment after the culture report? So treatment is based upon a score. Okay, that is curb 65, which we all know. Right, so 1 point is awarded for each symptom or each parameter, that is confusion, BUN more than 20, that is urea, blood urea nitrogen more than 20, respiratory rate more than 30, systolic blood pressure less than 90 or diastolic blood pressure less than 60, and age more than 65. Okay, so based on the score we'll decide what we want going to do with the patient, either we want to admit the patient or treat it on OPD basis. So more than equal to 2 requires the patient to admit in the hospital. Okay, so early initiation of empirical antibiotics is the key to the treatment of CAP. Okay, as it prevents the complications and decreases the morbidity and mortality. Okay, but once the microbiological diagnosis is done, we can add the specific antibiotic which the microorganism is sensitive to. So what are the common etiologies in CAP? Streptococcus pneumoniae, Haemophilus influenzae, Moraxella catarrhalis, aerobic gram-negative bacteria, mycoplasma and chlamydia. Okay, so what is the empirical treatment? We'll see. Curb 65 more than or equal to 2. So we are admitting the patient. Now we have to give IV drugs. So you can give injection ceftriaxone 1 gram 2 times a day, or injection amoxicillin 1.2 gram 3 times a day IV. With that, either ceftriaxone or amoxicillin, with that you have to add either azithromycin IV or per oral, like tablets you can use or IV. The dose is 500 mg OD and this treatment is 5 days. Okay, now when the curb score I said more than or equal to 2. Now if this curb score is less than or equal to 1, right, only confusion is there or BP is, BP won't be low unless and until there is a shock, right? So in that cases what you have to do is you have to treat on OPD basis. Okay, what tablets will start? Tablet amoxicillin, the dose is 625 TID, that is 3 times a day. With that, tap azithromycin 500 mg OD for 5 days. Okay, but sometimes the patient will have risk factors for pseudomonas. What are those risk factors? Like COPD, bronchiectasis, broad spectrum antibiotics for at least 7 days in the past month. Okay, history of antibiotic use, or corticosteroid therapy the patient is taking, and malnutrition. Okay, in that case the ceftriaxone it won't work, right? Pseudomonas cases, so you have to replace the ceftriaxone with other antibiotics. What are those? We'll see. One is piptaz, that is piperacillin tazobactam. The dose is 4.5 gram IV 4 times a day. Okay, or cefoperazone sulbactam 2 to 3 gram IV 2 times a day. Okay, up to 3 times a day in severe infection. Or cefepime 2 grams IV 3 times a day, or imipenem 500 mg 4 times a day, or meropenem 1 gram TID. Okay, so there are total 5 drugs you can use. What are those? Piperacillin, that is piptaz, cefoperazone sulbactam, cefepime, imipenem and meropenem. One out of this, whichever is available in the hospital, you can use that. Okay, So what are the remarks? Once the etiology of CAP has been identified on the basis of microbiological methods, antimicrobial therapy should be directed at that pathogen. Okay, so duration is usually 5 to 7 days, but it can be extended if indicated clinically. Right, fluoroquinolones should be avoided, guys, because there is a high burden of tuberculosis in India. Okay, one more point is macrolide, that is azithromycin, erythromycin resistance is noted now in Streptococcus pneumonia in between 9 to 20%. So we have to be careful while using macrolides now. And additional for empirical vancomycin has to be done. Now vancomycin, it is for MRSA, as we all know. For the patients who have the history of IV drug abuse or post-influenza pneumonia, severe CAP, symptomatically if it's severe, and associated with skin and soft tissue infections. IV drug abuse, skin infection, that is most commonly caused by staph only, right? Post-influenza pneumonia and severe CAP. Have to suspect for MRSA and start on vancomycin. Okay. So dose is 15 to 20 milligram per kg per day. Okay. What is the criteria for diagnosing the severe pneumonia? Okay. So either major criteria or three or more minor criteria will say that it is severe pneumonia. What is the major criteria? Invasive mechanical ventilation is needed. Second is septic shock with need of vasopressors, right? Minor criteria like respiratory rate more than 30, PF ratio less than 250, right? Multilobar infiltrates, confusion and disorientation, and blood urea nitrogen more than 20, WBCs less than 4000, thrombocytopenia, core temperature going less than 36, hypotension which is requiring aggressive fluid resuscitation. Okay, this will tell that it is severe pneumonia and we have to treat it accordingly. Next is coming to the hospital acquired pneumonia. Okay, what is the definition? It occurs after more than 48 hours of admission. Okay, and patient was not incubated at the time of admission. Then it will be VAP, that is ventilator associated pneumonia, but patient was admitted in the hospital for some other reasons and he developed some pneumonia after 48 hours. That will count as hospital acquired pneumonia. Okay, similarly ventilator associated pneumonia, it develops after 48 hours of mechanical ventilation, right? So when do you suspect HAP or VAP? Okay, it is more clinical diagnosis, right, with no gold standard diagnostic criteria as such. Okay, so one thing is that patient is admitted for more than 48 hours and he develops new or progressive infiltrates on chest x-ray. Okay, other than that he's having features like worsening features, either fever is worsening more than 100 degrees Celsius, leukocytosis, leukopenia, altered mental status, and with no other recognizable cause in the elderly. New onset purulent sputum or change in sputum character, worsening of gas exchange, right? That is a need of increase in FiO2, right? New onset or worsening cough or dyspnea, rales or bronchial breathing. Anything change worsening, we have to suspect for hospital acquired pneumonia or VAP, right? How do you confirm it? Hospital acquired pneumonia, we have to send the respiratory samples obtained by spontaneous expectoration or sputum induction or nasotracheal suctioning. Okay, and they are subjected to semi-quantitative cultures. Okay, culture growth is considered significant only when if it is the colonies are more than or equal to 10 raised to 5, right? VAP similarly, so respiratory specimens has to be sent which are obtained from endotracheal aspiration or mini broncho alveolar lavage. Okay, and similarly they are subjected to semi-quantitative cultures. Okay, ideal sample collection procedure is however the mini bronchoalveolar lavage, right? And similarly It is considered significant when it is more than or equal to 10 raised to 5 colony forming units per ml for tracheal aspirate and more than 10 raised to 3 for bronchoalveolar lavage. Right, so we'll see what is the empirical treatment in this case. Right, so most commonly pseudomonas we have to consider here, VAP and HAP. Other than a staph can be there. So what is the treatment? Similarly, what we saw that like whenever you are suspecting pseudomonas, whatever antibiotics we decided here, same antibiotics we are giving here. What are those? Piptaz I said, right? Cefoperazone sulbactam I said, 3 gram IV BD, imipenem cilastin 0.5 to 1 gram 4 times a day, meropenem 1 gram 3 times a day. Now we have to add one more drug, that is amikacin, guys. Okay, 15 to 20 milligram per gauge IV one time a day. Alternative to this regime is 2 drugs. Okay, but we have to put this drug as a last resort, okay, because to prevent the resistance. One is colistin and next is polymyxin B. Colistin dose is 9 million unit stat loading dose followed by 4.5 million units IV 2 times a day. On the other hand, polymyxin B 20 to 25,000 units per kg loading followed by 25,000 units per kg per day. Okay, you can divide this in 2 doses, right? So once the culture is proven for VAP and HAP, the culture reports are come. It can be Acinetobacter. These are the common bacteria which are seen in the ICU setups in the hospital or the hospital setting. Klebsiella, Pneumonia, Pseudomonas aeruginosa, right? So based on that, we have to select like whichever sensitivity the report shows. So mostly like Piptaz will be there, Cefoperazone sulbactam will be there, or carbapenems, the imipenem or meropenem can be there, colistin, polymyxin B. Similarly, like it is based on the reports, right? Now MRSA, if it's there, then we have to put injection vancomycin 1 gram IV 2 times a day, or injection linezolid, dose is 600 mg IV 2 times a day. Alternative to that is injection teicoplanin, the dose is 400 mg IV 2 times a day for 3 doses followed by 400 mg IV one time. Okay, this is for MRSA. Okay, what are the special remarks? Levofloxacin 750 mg IV once a day may be used as alternative to amikacin, right, as a second anti-pseudomonal agent. Nebulization colistin at the dose of 2.25 to 4.5 million units twice day or 3 million units thrice day can be used along with IV colistin. Okay. Next is colistin and polymyxin should be used only when there is resistance to all other tested antibiotics. Okay, as I said, in the patient with suspected VAP has septic shock and rapidly deteriorating status, empiric MRSA coverage can be added like vancomycin, linezolid, right? The choice between vancomycin and linezolid to be guided by patient specific factors, blood cell counts, renal functions and concomitant nephrotoxic agents. Okay. De-escalation should be done once the culture reports are available, right? The antibiotic selection based on that. Recommended duration therapy is 7 days if there is a good clinical response, or longer if clinically indicated, like immunodeficiency if it's there, or empyema patient has landed up into lung abscess, cavitations, necrotizing pneumonia, etc. So usually 7 days, like shorter regimen is preferred here because of the antibiotic resistance and antibiotic abuse. HAP or VAP due to Pseudomonas aeruginosa who remain in septic shock at high risk for poor outcome when the results of the antibiotic susceptibility testing are known. Combination therapy using 2 antibiotics to which the isolate susceptible rather than monotherapy is preferred. Okay, so Pseudomonas we have to be careful. 2 antibiotics we are starting like amikacin, levofloxacin and other anti-pseudomonal antibiotics. So clinical picture and procalcitonin levels may be used to guide the discontinuation of the antibiotics. Mainly clinical picture, improvement of the symptoms, also procal we can monitor. Ferropenem should not be used as step down therapy, right? Pheropenem, as it is the oral carbapenem, so we tend to put the patient on pheropenem and send the patient to home or shift to the ward, right? This should not be done. Okay, and tigecycline is not recommendedly routinely used, right? Even in our hospital, we use it only when it is like resistant to other antibiotics. Now coming to the Aspergillus pneumonia, which is also a HAP or VAP can be present like that, or even CAP, community acquired aspergillus infection can be there, especially in the immunocompromised people, like diabetes is there, HIV. In those patients, aspergillus pneumonia is there. So how do we treat that? We treat with voriconazole. Okay, voriconazole, the dose is 6 mg per kg IV every 12 hours, that is 2 times for 1 day. Okay, followed by 4 mg per kg 2 times a day. Okay, oral therapy can be used at 200 to 300 mg 2 times a day. Alternative to voriconazole is liposomal amphotericin B. The dose is 3.5 mg per kg per day IV. Right. Conventional liposomal therapy, the dose is less, 0.5 to 1 milligram per kg per day. Okay. Special remarks is use Blott's algorithm for diagnosis of Aspergillus pneumonia in critically ill patients. Primary combination therapy is not routinely recommended. Okay. Therapeutic drug monitoring should be done in the patient receiving voriconazole. The range is 1 to 5 milligram per liter. Right. Next, coming to the empyema. Right. Empyema, as we all know, it's a collection of pus in pleural space. Okay. There are these 3 stages: exudative stage, purulent stage, and organizing stage. Okay. When do you suspect empyema? Okay. When there is a failure of community or healthcare associated pneumonia to respond to the antibiotic therapy. The response is not there. We see the clinical improvement is not there. Right? In that, 20 to 30% of cases of pneumonia have parapneumonic effusion, and 5 to 10% of other parapneumonic effusion may progress to empyema. Right? So community acquired pneumonia, they will have 20 to 40% will have parapneumonic effusion, and within that 5 to 10% will lead to empyema formation. How do you confirm empyema? One is X-ray, right? But X-ray, you need at least 175 ml of the collection. Other than that, USG you can do. Okay, you can check for complex septated, complex non-septated, and echogenic pleural effusions. Like if the septations are small, ultrasound will detect that. CT scan, right? It will show parietal pleural thickening 86% times, pleural enhancement will be there, and split pleura sign in the 68% of the cases, and high attenuation of extrapleural adipose tissue in the chest wall. These are all the findings in the HRCT scan. Right. Other than that, pleural fluid analysis, that pus or positive gram stain will be their culture. It is the diagnostic of empyema. We have to send the culture samples from the pleural fluid. Right. What are the diagnostic clues in pleural fluid? That is acidic pH, pH less than 7.2, raised LDH, low glucose, and high protein levels. Okay. Suppose tuberculosis is there, we have to rule out. All the cases we actually send for tuberculosis also. For that, we send for Zn stain, gene expert, liquid cultures, and ADA levels. So ADA levels, CBNAT we usually do. Right. Other than that, gene expert is like PCR only. Liquid cultures, it takes a lot of time, so we avoid that. Okay. So the specimen for the culture should be collected during aspiration or drainage into aerobic and anaerobic blood culture bottles or RCM bottles, that is for anaerobic. Okay. And sterile containers, and not for the previously inserted tubes of the drains. Okay. Now coming to the etiology, the most common cause of non-tubercular empyema is Streptococcus pneumonia, followed by Staph aureus, Klebsiella pneumonia, Haemophilus influenza type B, and Enterococcus species. Right, and anaerobic species like Streptococci and bacteroids. Okay. Post-procedure hospital acquired MRSA and gram-negative bacillus are common. Okay, whenever you are tapping the patient and then the patient develops the empyema, in that cases MRSA and gram-negative bacilli are common. Okay, so how do we treat it? Principles are all patients with empyema needs to be managed in the hospital only, right? Image guided pleural drain must be put for all patients and large bore catheter should be preferred, right? ICD incision intercostal drainage should be put. Tube thoracostomy should be combined with closed CT or UAG follow up to confirm the adequacy of the drainage. Persistent of any undrained fluid should prompt additional drains or more aggressive management. Okay, ideal frequency and volume flushing are not established. Flushing with 20 ml of sterile saline every 6 hours has shown a reduced occlusion rate. Right? Intrapleural fibrinolysis should not be used routinely for complicated pleural effusions and early empyema. Right? We keep it like streptokinase and all. We use only when there is a fibrotic stage, lot of fibrous septations are formed. Only for that cases, we sometimes use streptokinase, but it should not be used for all cases routinely. Management of chronic empyema, which has organized and is compromising lung expansion, may need surgical treatment. Okay. So, we'll see what is the treatment. Empirical antibiotics we'll see for community acquired empyema. Right? If there is no risk for MDR organisms, like any respiratory illnesses or immunocompromised state, right? In that cases, we have to cover cover anaerobes empirically even if the cultures are negative, right? What is the preferred regimen? Amoxiclav 1.2 gram IV 3 times a day or ceftriaxone 1 gram IV 2 times a day plus, this is the main thing. So we have to cover the anaerobes also. How do we cover that? By adding clindamycin. Clindamycin dose is 600 mg IV 3 times a day or metrogyl also can be given 500 mg IV 4 times. Right? True antibiotics for adding amoxiclav, ceftriaxone or clindamycin or metrogyl. Alternative is piptaz. Right. Now those patients who are who are community acquired with risk factors for MDR, that is multi-drug resistant. Okay, what are those risk factors? Antibiotic therapy previously history, recent hospitalization, immunosuppression, pulmonary comorbidities like COPD, bronchiectasis, right? Probable aspiration, multiple medical comorbidities are there like diabetes, alcoholism, etc. So in that patients we have to cover the pseudomonas mainly, right? Like, so what drugs we are using? Cefoperazone, sulbactam, 3 gram IVBD, that is what we know, or TDS based on the clinical scenario. Piptaz. Alternative is imipenem, cilastin, cefepime, plus we have to still add here clindamycin or metronidazole. Right. So instead of amoxiclav or ceftriaxone, we are using those specific for pseudomonas. Right. And those patients empyema who are post procedure, right? Suppose diagnostic pleural tap you have done, after that the patient has developed the empyema. For that cases, prefer antibiotics are cefoperazone, sulbactam, piptaz, teicoplanin we are adding here. Okay. So cefoperazone or piptaz with teicoplanin we have to add, or vancomycin. The dose is 15 to 20 mg per kg per dose. Okay, 8 to 12th hour we have to start. Alternative imipenem, teicoplanin, okay, for 3 doses followed by OD or vancomycin. Imipenem we have to add with teicoplanin and vancomycin. What are the special remarks? So presence of air bubbles within the pleural effusion in the absence of preceding pleural intervention is specific for pleural space infection and may suggest resistance to chest tube drainage alone. Right? And pleural pH, that is acidic less than 7.2, LDH more than 1000, glucose less than 40 or loculated pleural effusion predicts a complicated clinical course. Avoid aminoglycosides inactivated in empyema fluid. Right? We have to avoid amikacin, kanamycin, capreomycin because it will get inactivated in the empyema fluid. So change in antibiotics when culture and sensitivity reports are available, as we do for pneumonia also. IV to oral antibiotic switch. When we do that, if the patient has responded to the therapy and there has been source control, then a transition to oral therapy can be made. Switch to oral therapy can be made only when the organism is susceptible to the oral antibiotics only. Okay. If not, then there is no use of switching. Switch to oral antibiotics in culture negative cases should not be done. Right? So it's all based on culture therapy and clinical. So this was the short